Hey, Miriam.
Mm-hmm.
So it looks like you are me, because I think that computer automatically puts me on there. So let's undo your video.
Okay, can you see me? I still can't see you.
You have to undo your video.
Undo my video. What do you mean? Are you there?
Yeah.
Okay. So now, okay, now I can see you.
So open your video.
6 p.m. At the bottom?
Yeah.
Start Zoom. Start Zoom. Maybe
Start
that. Sign in. I don't. Say that again.
Do you see me talking?
Yeah.
Okay. Do you see your screen?
I see the computer screen. Yeah.
Do you see a picture of me?
Yes.
That's you.
Okay.
So you need to.
Yep. So now you're side by side.
No, but you need to open yourself. That you are me. My picture is you.
So do I click on it?
You need to start your video.
Okay. Let's see, more, stop recording, chat. I don't know how to start the video. I can.
At the bottom where it says mute, start videos, participants, chat. There's this.
Okay, so it says, so, okay, got it.
Okay.
Sorry.
All right. I guess I just got a message from Lauren saying, are you the host of the meeting? I clicked the link and it says host will let you in soon. I'm not sure. I don't see anybody in the waiting room and there's nobody else on here.
Yeah, it seems like my patients are Emma is trying to join the call, but I was confused and thought the link was in the text you sent, so she's trying to now. Okay. So it says 5 people have entered the waiting room for this meeting. See waiting room?
Oh, so you're the host. You're the host. Okay.
Yeah.
All right, fine. Yeah, see waiting room.
Okay.
And just admit people in. You have to also change your name there.
Okay.
Hello.
Hey, how are you guys?
Good, how you doing? Thanks for joining.
Thanks for inviting us.
Is that Justin?
This is Justin.
Hi, nice to meet you.
You too.
This is Reggie.
Yeah, Reggie.
Hi, Reggie.
Hi.
Hi, Catherine.
Hi.
How you doing?
Doing good.
Thanks for joining.
Of course.
Hi, Lori. Let's unmute all. Let's see.
Yeah. Just unmute that. There we go.
Lori, can you hear me?
Yes.
Okay, good. Thanks for joining.
No problem. I just saw your email, so I figured I would pop in.
Good, thank you. We're just waiting for a few more people.
Okay.
Miriam, can you do one thing? If you go up to your picture and the little blue icon pops up.
The 3 dots?
3 dots. Yep.
Uh-huh.
Hit that. And then
rename.
You can change your name. We don't want to. We don't need any more than one of me.
Oh, yeah.
Okay. Okay. Yep.
There we go. Dr. Miriam is on the case. All right, so we're waiting for a couple more people to come in. Thank you for coming on today. This is our Ask the Expert call. We've had such great responses from these calls. And we see it as a great way to provide a service to our PT community and the community at large, because there's a lot of misinformation or misunderstood things out there And really, when it comes to community health, we really have to step up and take responsibility and provide good information out there. And Dr. Miriam is an expert in this condition that she'll speak about today. And as a parent, I'm a parent, and everybody here on is also in the same boat of having kids, and nothing's harder than seeing your child go through something that's just so difficult, and you don't have an answer. You can't seem to get to the right person, and you just keep going down this trail of things. And the more times that somebody tells you it's not this, the medical community often will say, oh, good, it's not this, but they don't actually leave you with a better answer and nowhere else to go. And that's what we've seen is so frustrating. So we thought it's imperative for Dr. Miriam to come on and share some information for you guys, and really explain that there is some hope and there's a light at the end of this, and that there's ways to get some help. So thank you for coming on, and I'm going to turn it over to Dr. Miriam. I'm going to just say one more thing before she gets going. Dr. Miriam has been with us for almost 4 years now. And I didn't know about AMPS before she joined our team. And most likely, if someone came to us with this condition, I would have misunderstood it and misdiagnosed and mistreated it as well. And so that just, personal experience, I probably have not, done good service to people by not knowing about it. And so even people who say they might know, they really, really have to have a specialty in it. So Dr. Miriam, we were so happy that you came on board with us 4 years ago, and it's been great to see the kids change over time. I mean, my gosh, the life that comes back to them is just so great, and it makes just working with them worth it for us to be able to provide some benefit and life back to these kids. So take it away, Dr. Miriam.
Okay. Well, thank you. I enjoy it too. And it's a very rewarding group of patients to work with for a lot of different reasons. I think there's still a couple people that are trying to get on. Should we give a few more minutes? I think they may be having trouble with the link.
Yeah, give a couple more minutes.
Okay.
But if you want to make me the host, and then I'll be able to monitor that if people are trying to get in. I know it's strange today. Usually we have more.
How do I make you the host?
If you go up to the participants.
Okay.
And you go over to more.
More, Rename again?
No, just say it'll make host.
Okay. When I click more, it just goes to rename.
Okay. Well, if you can manage the participants, then that's
okay.
Just look down at the bottom and see if anybody participants.
Yeah, I think. Oh, okay. I see. Admit all. Okay. So there's 3 more people that just joined. And then,
there we go.
Yep. Then let me try to get the rest.
All right. Linda's here.
Hi, Linda.
Lenore's
Hi,
here. Lauren's here.
Sorry, Lauren. I wasn't letting you in. I apologize.
We were wondering where you guys were. What did you do? Do you think we weren't coming on today? Did you think we were doing a rerun like we did last week?
Lauren and I were on, and we were like, "What? Oh, there's no call today."
So Matthew, a couple of weeks ago, you had Jay on with the golf.
Yeah.
Did you ever rerun that? I mean, did you ever put that on so other people could look at it?
We replayed it, but we'll do a rerun at some point as well, just to get people to have access to everything.
Oh, so you did replay it? Like
we replayed it the next day, yeah.
Oh, okay. I'll look in my emails. Maybe I just missed it.
Yeah.
But also the ebook, did that, was that included in the follow-up the next?
That'll be coming out this week.
Oh, okay. So it hasn't come out yet.
Nope.
Okay.
Well, actually, it was ready to go. To be honest with you, it was ready to go. And I said, we really should probably have some other bonus material in here. So Jay and I got on this like brainstorm about how we can add even more, not information to the book, but links to be able to get videos to see not only, you know, the exercises on paper, but then videos of the exercise. So we're putting some bonus material into the book.
Oh, good. Okay.
All right.
Okay, I just resent the link to a couple patients, hopefully.
Yeah, if you just, I apologize for the technical difficulty, everybody. But Miriam, if you can make me the host.
Okay,
You see the
so,
participant list there.
okay, so it says Miriam, host, and then if I do more, rename, okay, so I'm gonna rename, oh,
You can click my name and then say, make me the host.
okay,
That grid view. Or you want
let's
to
see.
just do that? Where'd she go? Oh, there she is.
Let's see if. Did that work?
Yep.
Either-
Right. No, let's move ahead. Sorry, we're
Okay.
much better therapists than technical.
All right, so let me,
That came in here.
yeah, I
Alina
think we have a
here,
couple
great.
more people that just called in.
All right, you're just gonna have to watch the host.
Okay, and just admit them when they pop up.
Yeah. So again, a very misunderstood syndrome, very difficult for parents to get through, as well as the children, of course. And we're so thankful to have Dr. Miriam on our team, as well as able to reach out to all of you and provide some hope and some information and inspiration, truly, actually, that she provides to her patients. And we just get inspired seeing them come to life when they're working with her. So Dr. Miriam, why don't you take it away?
Okay. Hi, everybody. Thank you so much for joining this call. So Matthew introduced the syndrome that I'm going to talk about, and I just wanted to give a little bit of my personal experience with it. So I started treating AMPS probably about 10 years ago. I was working in a clinic in Millburn, and a patient came in, a young girl, she was about 12, and she actually crawled into the office. So I'd never seen any presentation of AMPS before. She was unable to stand. She was literally crawling into our office. So when she first came in, we asked tons of questions. What could have caused this? Why was she presenting and walking and crawling into the office? How many years had she experienced with this? We were completely confused. So the owner of the practice that I was working with and I really decided to kind of research this further. And we found that CHOP, Children's Hospital of Philadelphia, had really coined the term AMPS and really was the leading researcher in this syndrome. At that time, it was very rare. It's still rare now, but it really, an outpatient physical therapy practice, really, we had no experience with it, and none of my colleagues did either. So I went down to CHOP to be trained several times. I also went to Children's Specialized. We had some contacts at Boston Children's Specialized as well, and we created a plan to treat them on an outpatient basis. So for me in the beginning, it was incredibly interesting. It was also heartbreaking too, to see these kids struggle the way they were, physically, functionally, emotionally. So it truly became a passion of mine, not only for the physical therapy component of it, but also the connection that you make with the family and the need to research and educate families about this, because there's just so little help for it. For me, it's been really enjoyable. Every year it's grown into something larger. When I came to this practice, most of my patients came here, and we've developed it into something more here. And now through telerehab, it's becoming something virtually at home. So it continues to grow as things change in the world. And it's just been very rewarding as a PT. And I feel very fortunate to work with these patients. We create a really strong bond, as Catherine knows. And I push her really, really hard, and she accepts the challenge every time. And it's just been a really rewarding experience. So the presentation today is just to educate the audience about AMPS in general, but also to answer questions for the patients themselves who are dealing with AMPS, to talk with each other and also create a network for each other, because that's really important considering how rare the syndrome is. So if there's not any questions, we have the chat open if you want to have any questions in the group chat, but also at the end I'll answer questions and I'll go through a little presentation before that. Okay.
Can you just make your put it to speaker view? so we can see we're focused specifically on you.
Speaker view. Got it.
All right. You should
Okay.
see mostly yourself.
Okay. So let me do share. Okay. Can everyone see my presentation?
Yes.
Okay, great. Okay. So chronic pain in a pediatric population. So this is an example of an exercise that my patients will do. It's an important weight-bearing exercise. So this is considered an animal walk, which is kind of the beginning of a lot of the higher intensity exercises that these patients do. So this is a really, strong example of what's expected of them on day one. So think about if a patient comes in and they can't bear weight through a limb, and then you ask them day one to be in this plank position, they'll think you're out of your mind. But these are the expectations, and I'll explain why, that this is what's expected to really get the patient moving and get them moving quickly. Okay, so what is AMPS? So by definition, it's called Amplified Musculoskeletal Pain Syndrome. In its simplest terms, it's an overreactive reflex which causes constriction of blood vessels. So that's, to be honest, it's a hypothesis. We're not sure if that's exactly what happens, but in terms of the framework to explain to patients, that does make the most sense in terms of the nervous system response. So there's a reflex, and I'll explain on the next slide. So there's an overactive kind of loop in the nervous system. So there's a painful response, say someone touches your arm, and then that response goes to the brain, and the brain interprets that as pain. And then it comes back down, and the response dwindles. In AMPS, it does not dwindle. It gets amplified and amplified, almost like a sandstorm, and it gets bigger and bigger. And the treatment for it is aggressive physical therapy and other things that we'll talk about next. So it's a mild pain signal is amplified into a very painful signal. Allodynia, which is kind of a trademark of the syndrome, in which it's a response to something that's normally not painful. So if I was to hug a patient and then that's painful to a patient, that's normally not painful. Or if you shake someone's hand, that becomes painful. So allodynia is a trademark symptom of this syndrome. Oftentimes people have pain when they put on a sock or a glove, when they pull the sheets up at night, when they put on a pair of jeans. So those are all different examples of allodynia. Okay, so symptoms of ANPS can be incredibly varied. So they can be a pain in an ankle, a pain in a hand, a pain in a thigh, a pain in the back, jaw, headaches, fatigue, abdominal pain. So there's no one body region that it affects or body system. So it can affect your pulmonary system, your ability to breathe, brain fog, which is fatigue and some mental capacity issues. It can cause musculoskeletal pain. So it's not limited to any body system. And usually it's caused by minor trauma. In fact, more research has come out that there's no trauma that seems to be associated with ANPS. So originally when I was treating these patients, it was thought that maybe there was some orthopedic trauma that contributed to this syndrome. There seems to be really no link. A majority of my patients do have a little bit of musculoskeletal issues before, like a sports injury or perhaps an overuse injury, but more and more the research is showing that it can just come from a non-traumatic event. Oftentimes, some of the patients have skin temperature changes. So you can see a blue, purple, or red presentation, almost like mottling, where it's white and red kind of mixed in. You can see swelling of the affected extremity and vascular changes. But I would say a majority of my patients do not have those. So even though that's considered like a trademark of the diagnosis, most of my patients do not have these skin changes, which kind of is frustrating because when you look it up online or you talk to someone, if they ask you those things and you don't have them, then you think, oh, maybe it's something else. But oftentimes those aren't present. What is present often is something called conversion response. So this is a physical response to emotional stress. So this is an example: a child goes blind after seeing a dog run over by a car. So that's the most extreme form. But this conversion disorder is very common in ANPS. So basically it's a physical or emotional stress, and then the response is lack of function. So lack of ability to walk, like in the patient that crawled into my office. I had a patient that lost the ability to write with her dominant hand after having ANPS diagnosis. So she had to learn to write with her left hand. So it's a conversion or loss of function because of the stress. So that I see is very common in the patients that I treat. So this is the abnormal reflex framework. So you can see that there's a stress, injury, age, or genetics. Those are the thought, they're not positive, that those might be the things that cause this abnormal response or pain. So the stress, injury, illness, age, and genetics may contribute to this amplified response. So you can see the pain star. So you might touch someone, give them a hug, squeeze their hand, or, I mean, it really could just be brought on by sitting down. It can be anything. So the pain goes up to the brain. The brain recognizes that as painful, but it also goes down to through the spinal cord and then down to the neurovascular nerves, which then goes to your limbs. And then it further constricts those blood vessels. And that's what they think, because the decreased blood flow, that's what further contributes to pain. So you can see it goes up to the brain, but then it goes down also to the limbs. So it's twofold. Your brain is recognizing something that shouldn't be painful. And then it peripherally or on the extremities causes blood vessels to constrict, which further creates this pain cycle. So then you get this storm of pain. With decreased blood flow, it decreases oxygen and increases acids, which then also further increase pain. So this is the framework for why they think it happens, but they're not exactly sure if this is what happens. This is how they explain the overactive nervous system. And I think it's also more digestible for patients to see this picture because it goes up to the brain and then it also goes to the body part. So when patients sometimes ask me, like, you know, my friends, I'll talk about it with my friends and they'll think that it's made up. Nothing about this syndrome is made up. Your brain is interpreting a non-painful stimulus as pain. So your body thinks it's pain. It's just amplified as compared to what it was, you know, a few years ago or 6 months ago when it wasn't painful. So you are interpreting it as pain. Any questions?
Yes, I have a question.
Sure.
What you were talking about with the conversions,
Mm-hmm.
could that damage, like, could that be permanent?
No, so in the patients that I've seen, conversion disorder is not permanent. I don't know if it can be permanent, but in my experience, it was not permanent for those patients.
Okay.
So through physical therapy, aggressive psychological therapy, and a support system at home, they were able to regain function. So, and there's varying degrees to conversion disorder too. So basically the beginning of AMPS is in itself conversion disorder. So it's lack of function that you were able to do prior to this diagnosis. So conversion disorder is like the most extreme form, but I have seen it in some AMPS cases. Let me just let in a couple more people. Let's see.
So Miriam, I have a question. How fast?
Yeah. Hold on, you just say that again?
How fast does that come on?
So we'll get into that and I think in the next slide or two. So it doesn't come on fast usually at all. In fact, the norm is that it takes several months and or years to get an AMPS diagnosis. It can come on, I would say an average, probably at a minimum, it takes at least 3 months to diagnose, but it usually takes months and months because it's a true rule out diagnosis, which we'll get into next. You have to make sure you do a myriad of tests to make sure there's nothing else that could be contributing to this pain, but it takes several months to get this diagnosis. Okay, so diagnosis of AMPS. So children with AMPS have usually failed every other type of treatment. So, so this is what I was just explaining. So every single one of my AMPS patients without fail has probably had countless x-rays, MRIs, CT scans, blood work, Lyme disease, everything. Because best practice is that you need to rule out whatever could be causing this unknown source of pain. So that's an appropriate plan of care that they should make sure they go through before they get the AMPS diagnosis. But because of all those tests, it takes months to figure out what's really going on. And despite having negative results in all those diagnostics tests, if they're not sent to a physician that has seen AMPS before, they still wouldn't get the diagnosis. So until they find CHOP or Boston Specialized or Children's Specialized, or perhaps their pediatrician or physician knows somebody that's dealt with AMPS, they still would have an answer that their doctor doesn't know. So that's why it can take so many months to truly diagnose this syndrome correctly. So there's many names for it. In an adult population, it's more commonly referred to as complex regional pain syndrome, or CRPS. There's differences between the two, so they're not completely synonymous. Usually CRPS is brought on by more major trauma. So an orthopedic injury like an ankle sprain or an ankle fracture or a period of immobilization in a cast or a boot. In AMPS, we usually don't see that, like I said before. So there's very little trauma that's usually precedes the diagnosis of AMPS. It also can be known as pediatric fibromyalgia. I used to hear that term used more when this was first kind of floating around. Now I don't hear that as much. Myofascial pain syndrome, neuropathic pain is still something that it's commonly referred to, psychogenic pain, and reflex neurovascular dystrophy, RNSD or RSD. So RSD is still a common term that they use. I think CHOP still even uses it sometimes. So if you see those diagnoses, they're similar to AMPS, but there's a little bit of a difference between the two. You would treat them very similarly.
Miriam, can I say something about this?
Sure.
So again, I have over 20 years of orthopedic clinical physical therapy experience. I've got a specialty in orthopedics from the Board of Physical Therapy. If I didn't know you, if we didn't meet 4 years ago and you didn't come on to our practice, I probably still today would be looking at that and saying ankle sprain. And the parents would say, well, they didn't really sprain it, or they don't, they didn't have a fall or anything. They don't participate in sports. And, I probably would have searched my brain, but still come back around to ankle sprain. And I would have gone ahead and treated that. And then it wouldn't have gotten any better. And then we would have gone for MRI or something like that. And down this would start again, from even, self-admitting somebody with experience in the field. I would have started that sort of long ride or journey for the patient in looking into this when it was really presenting, as something orthopedic.
Yes.
And that, this is why we have to provide information out to patients, to the community, to other professionals, so they can shorten that journey for the patients, for the children and the parents to go on, because that's the true emotional toll, I think, that comes with this.
Yeah.
And the more time that goes by between diagnosis and, actually good treatment for this specific syndrome, if we can shorten that journey, that's all better.
Absolutely. Yeah, that's part of the struggle and the mental fatigue that the parents face, is that it's so many months of going to doctor after doctor with no answers until you find someone that has at least heard of it. And then once someone has at least heard of it, then you don't even know where to go for treatment. So it's all these hurdles you have to get through before you actually start feeling better from the syndrome itself. So yeah, it's a really uneducated, a lot of people just don't know about it, and it's just not common enough, and there's not enough people that treat it. So spreading the word is really important. Having a community that people can reach out to, including mental health practitioners, physical therapists, physicians. So it's a team approach that's most important, but just getting the word out to patients. Because my mom is a teacher in California, and a few years ago, she had a patient, a student, who ended up being diagnosed with AMPS, and she told me, one of my students complains of abdominal pain. I mean, really severe abdominal pain. She's had this test and that test, and it's been going on for close to 3 years. And it was AMPS. No one there had ever heard of it.
Mm-hmm.
So she had to fly to a different state to get diagnosed. So, yeah. I mean, it's something that really needs to be brought to the community's attention.
Yeah.
Okay. So next, let's get into treatment. So treatment of AMPS. So Catherine can attest to this. It's aggressive therapeutic exercise to retrain nerves. So aggressive is a little bit of an understatement. So it's intense, really intense. So in the beginning, you assess what the patient can do. So like I told you in the beginning, the patient that came in that was crawling into the office, obviously it wouldn't be appropriate for her day one to be doing burpees. But her function that day was addressed by having her stand up and walk on 2 legs versus crawling. So it's all individualized based on what the patient can do, but right away you are strongly encouraging them to get moving in a challenging way. So in addition to exercise, they're also doing desensitization of the skin. So oftentimes, like I said before, just putting on a pair of jeans or socks can be really painful. So desensitization is also a hallmark treatment for this syndrome. So what we do for that is a variety of things. So an ice massage, so you could freeze water in a Dixie cup and then do a 5-minute ice massage. A hot and cold, we call them a contrast bath. That's still a really important treatment to do for these patients. Just sometimes getting like a rough towel and rubbing it over the area that's really sensitive, taking socks on and off, putting shoes on and off, getting dressed with different materials on their skin. So desensitization is a huge part of treatment. There's also a technique called cupping, where basically you create a C with your hand and you create this cupping. So you're literally making a cup across the limb that's tender or very sensitive to pain. There's all these different techniques. We also use the hypervolt behind us. So that's a percussion massage device. So it's similar. There's varying intensities of it. So there's a Theragun model, there's the hypervolt, there's lower intensity models. So all those are different tools that you use to decrease the sensitivity. There's a lot of things that we can use at home or in the office. But most important in regards to the treatment is you're focusing on function. So in the physical therapy aspect of this, we're not really asking about their pain. So the patient presents with really severe pain, usually 10 out of 10 or higher. But the physical therapy part is all about function. So the goals will be completely based on that. So a patient comes in, and if they present by crawling in, the goal that day will be to leave the office walking. Or if they're unable to stand for X amount of seconds, the goal will be to stand for double that amount. So it's all about function, getting them back to their normal activities, back to school, back to athletic activities, dance, whatever they weren't able to do functionally is what our goal is. So oftentimes the most challenging position or exercise for a patient is what I'll have them do. So it's the opposite of how you would treat an orthopedic injury. If there's a patient that comes in and they say, that hurts when I do that, you would back off. It's a red flag or a warning to say that there's something wrong, it's causing pain, we need to look at other areas. In an AMPS patient, you do exactly that. So you have to push through that pain. So hence the huge psychological component of it. So that's the next bullet point. So this multidisciplinary approach is huge. So a patient will simply not be as successful unless they have the support of an MD, a PT or OT, depending on who's treating them, and a mental health professional. When I first started treating these patients, it wasn't always required that they also have a counselor or psychologist or a therapist to talk to about this, but really the driver of this is a stress. There's some stressor, and it's causing the manifestation of pain through these physical issues. So everyone has to work together to really understand, why is this coming out this way? What are some strategies to help deal with the stress component? And then functionally on the PT side, how can we get them moving again? So it works best when everyone works together. So now when I have these patients, if they don't have a therapist to speak to, then we try to connect them with someone. Usually most do coming in because they've had so many months of dealing with this and it's so limiting them in their life in general. But it's really important. It really can't be understated how important it is to have that team approach. And there's also outpatient or inpatient treatment. So in this setting, we do outpatient, but inpatient treatment is a little bit different. Not many hospitals provide that, but CHOP is the most well-known area. Children's Specialized has one, Boston Specialized has one, and you would go there for 2 to 4 weeks, depending on what's needed. And it's a very rigorous treatment there, and it involves this multidisciplinary team approach too, that I can get into more if anyone has specific questions.
I'd love to just second that mental health aspect. I mean, for anybody going through a tough condition, it's the mindset, which is often one of the key factors that gets in the right position or the right framing. And you know, we provide motivation and encouragement, and also, you know, information. But the mental health part of it, I think there's, I guess, maybe a stigma with mental health, and people think they can do it on their own. But you know, look at the professional athletes. Let's just use them as an example. They all have, you know, mental health performance coaches or psychologists. You know, those people exist to help increase performance. So if you're in a painful situation and you don't want to, you know, that's tough in itself. And then you start admitting to yourself, well, maybe there's a mental aspect to this too. That can really further weigh on you, and you may not actually take that step toward seeing a mental health professional. But so I just want to reemphasize, I can't say that how important that is. And it shouldn't be thought of as a stigma. You want to improve every part of your being, and the mental part of it is just as big as the physical part of it. And, you know, take, for example, the other people who are trying to deal with things, professional athletes, you know, people in business, they all have coaches that they usually go to for the mental part of it. So let's just be done with the stigma of any mental health requirement. So
Yeah, that's an excellent point. I think in the beginning, when I would talk to patients and their parents about it, I would tend to there was no stigma personally, but I didn't want to make the patient feel uncomfortable. But I completely agree that sports psychologists are employed for elite athletes. I mean, it's just like a trainer, they equally have sports psychology team behind them. So it's very important also to discuss some of the feelings that you have associated with AMPS, not what even brought you to the AMPS diagnosis, but how it makes you feel in your life post-diagnosis, because it's really limiting in a lot of ways, and it's hard to talk about it with your friends and your family because it's so rare. So it's really important to communicate and kind of get everyone on the same team. And to find someone that you trust, just like as equally as important as it is to trust your physical therapist, it's just as important to trust your therapist that you talk to about this syndrome as well. Okay, so now the fun part. So the treatment of AMPS. So the kind of hallmark treatment are these things called animal walks. So you can see in the top picture, one of the patients is doing a crab walk. There's duck walk, bear crawl, three-legged dog. So they're called animal walks because they're named after animals, but more specifically, they force the whole body to engage in the exercise and move as a unit. And in the beginning, it's not going to look pretty because remember, there's significant pain and limited function because of the syndrome, but the purpose is to get moving and start to get some function back. So these are timed usually. You have a set amount, and then every time you have to increase how fast you do it or how far you go. So everything in the beginning is very, very objective. And really throughout the whole treatment, it's very objective. So everything should be timed. You do a certain amount, and then you try to beat that amount or master it. Depending on what body part is affected or where the pain is would kind of indicate which exercises you would do. But this is a common place that a lot of people start when they have lower extremity issues, because you can see in all of these pictures, they're weight bearing. So they're putting weight through those limbs. So that's a real key part of treatment, is you want to put weight through the limb and make sure that you're putting some pressure on it. So in addition to that, we do planks and lunges. I'm a big fan of burpees. We do a ton of burpees. Yep. So that's something that's really important. They're challenging for the cardiovascular system. And I also think mentally and emotionally for a patient, when I say burpee to any AMPS patient, they're like, I'm not doing a burpee, that's insane. But the fact that they do it and know that they can do it, it's so motivating to them. And it's a breakthrough. I see it with every patient. Once they see that they could accomplish that physical feat, they're like, I can't believe I did this. So I like to see it, I like to utilize it for that because it's really motivating for them on an emotional level. And you can see the goal with every treatment session is restoration of function. So that's really important. So regardless of that 12 out of 10 pain, 10 out of 10 pain, we have to push through function. And I'm not minimizing how terrible it is because it's severe pain. But the goal is to really get moving and achieve greater function than you did the day before. So it always goes back to that. Okay, so let's get into the outpatient inpatient program a little more. So outpatient program is usually required before acceptance to an inpatient program due to insurance limitations. So oftentimes the reason why I do see kids in an outpatient setting is twofold. It's because they didn't even know that there's an inpatient choice possibility. So they come to me first on an outpatient basis, or they've tried to go to inpatient and they can't because they have to fail at outpatient first. And that's an insurance limitation. The sessions usually are between 2 and 5 times a week with additional completion of home exercise daily. So the home exercise is hugely important. So if you're coming into me for 1 hour, 2 to 5 times a week, but then at home you're not doing any of your exercises, you'll find that the ability to get better will be slowed or won't be there at all. So it's really, really important to do your exercises at home. And then counseling sessions with a therapist or psychologist. Inpatient program, you're in a hospital, so you're staying there and sleeping there. It usually lasts 2 to 4 weeks. It's 5 to 7 hours of daily exercise. Combined with that is individual, group, and family counseling, and then tutoring if it's during the school hours. So you can see the inpatient program is much more intense, as it should be, because you're staying there. And it's usually consolidated to 2 to 4 weeks. And these are the programs I'd explain at CHOP, Children Specialized in New Brunswick, Boston. I think Cincinnati also has one. There's not that many in the country. And they're very hard to get into. There's very limited space. Hard to get into just because there's so few programs and they accept so few kids. Anyone have any questions?
I have a question.
Mhm.
So at what point do you push your child? Because Justin does PT 5 days a week for an hour, and he's spent after that. At what point do you say, yes, you have to get up and do exercises? What's appropriate, the appropriate amount versus inappropriate? Where do you draw the line, and what's the protocol?
Good question. So as a parent, it's incredibly hard to push your child when you know they're fatigued and in pain and utterly exhausted. The protocol at CHOP is that if you have a fever or you're vomiting, you have to exercise. So it's intense. So unless there's a virus or something else going on that would be outside of the syndrome, they push you to exercise. So if he's going to PT 5 days a week for 1 hour, then he should probably be doing at least another round of exercise that day.
Okay.
So and another round of his home exercises.
Okay. So like whatever circuit they give him, he should be doing that later in the day.
Yep.
Okay.
And that's at a minimum. In addition to that, there shouldn't be a lot of like sitting around or lounging around. It should be really prolonged activity. So there can be short breaks broken up by schoolwork or something more leisurely, but it should be sustained exercise throughout the day. Not as high intensity as the home exercise program, but a walk, a bike ride, shooting hoops outside, playing soccer, things that keep you active.
Okay. Thank you.
You're welcome. Okay, so AMPS prognosis. So after roughly 1 month, about 80% have no pain and are fully functional. So it's a very positive prognosis. Another 15% are fully functional with mild or recurrent pain. 5% are no better, and about 15% of children will experience a significant relapse within the first 6 months. So I have seen this, the relapse, probably out of all these bullet points a little more frequently because of the lack of completion of home exercises. So after they're in inpatient program or they complete their outpatient program, it's really important to continue with your exercises at home because that's what keeps the function going and then slowly chips away at that pain wall. So the pain wall just doesn't come down in a big crumble. It's like chip, chip, chip until you make a big crack, and then you start to see some changes in your function and slow decreases in your pain. But it's really important to keep up with that home exercise at home. That's really significant. Okay, so I just wanted to show you a quick video about a success story from CHOP. So it's a YouTube link. I just have to stop sharing this one, and then I want to show you the screen. Hold on 1 sec. Okay. Let's see. Can you guys still see me?
Yeah, we can see you.
And you can see the video too?
Not yet.
Okay.
You gotta share again.
Hold on. I lost my share video again. Let's see. Share screen. Sorry, guys. Let me try to, usually there's a new share option. I just can't find it. Now you just see me. You don't see my PowerPoint?
Yeah, we can see you, and just if you click that share screen, and it'll open up with a new panel.
The new share went away. Okay, let's try. Okay.
There we go.
Okay, so let me go to. Okay.
So we see your slide.
You still can't see the video?
No, we see your slide, your last slide. So why don't you close that down all the way?
New share. Okay. Now you just see the slide. Okay. You're still just seeing me, right?
Yeah. We can also send that out as a link in an email if people want to take a look at it.
Yeah. Let me, yeah. Okay. I will definitely send that out in an email link. Or I could try, you know what I could do? I could try to share it in the chat too.
Yeah.
Okay.
Put the link in the chat.
Yeah, let me do that. Okay.
There we go.
Okay, let me see. Did everyone get that link?
No, I don't see anything in the chat.
Mm.
Anybody have any questions?
I have a
Hold on.
question for Miriam.
Hold on one
Can you hear
sec,
me?
Lauren. Let me.
Oh,
one
sure.
sec. Let me. Now the
Sure.
video's playing. Sorry.
Oh, it's okay.
Let me
Oh.
close it. Hold on. Okay,
Oh, are you ready?
I'm ready.
Okay, so in terms of timing of performance of the exercises, what do you recommend? Do you recommend that they do it based on like a schedule thing, or like when symptoms occur, or like does it depend on the case and stuff?
So definitely a good question. So definitely something scheduled. So when these patients come in with a AMPS diagnosis from a physician, you get them started right away on an exercise program to really address their specific functional loss. So if they're not able to stand or walk or use their hands, so everything's related to the function that they lost. And they should do it on a regular basis. Every day, usually we set a schedule of 2 to 3 times a day. In the beginning, it's a little bit less. You kind of want to build some stamina up, but right away they're doing more things that they had done prior to that, without question. But it's definitely not as the symptoms arise, because there's a pretty consistent level of pain kind of characterized by this syndrome. So you don't want to wait until the pain, usually patients will tell me I have 10 out of 10 pain upon waking. So the pain is already really high. There's times when they can say it gets higher, but you want to be really consistent with kind of your approach to having them do their exercises.
Great, thank you.
Good question. Okay, just.
Miriam, I have a question about, again, about being a parent and, you know, your child has a pain and a problem, and you go to the pediatrician and the pediatrician says, oh, like, let's wait and see. At what point do you, I guess, as a parent, start like looking further and further? I know some people maybe are a little bit laid back, whether it's the parent or the pediatrician. I think a lot of times the pediatrician's job is to be a non-alarmist.
Mm-hmm.
That's probably the biggest thing that they do, and that's certainly a good quality in a pediatrician, that they don't alarm parents of every little thing.
Mm-hmm.
Also, in some cases, as a parent, things seem to take a bit longer. At what sort of is there a set time frame when we should maybe be seeking further information, or talking to a specialist like yourself, or looking into the CHOP program? Or
so there's kind of stages into diagnosing AMPS. So initially, when it's an orthopedic injury, usually there's a set time frame, like an ankle sprain or a wrist sprain or a back injury, that thing should, as an orthopedist or a physical therapist, there's a set time frame that we all know, like this should kind of resolve itself in a certain amount of time with rest, physical therapy, and appropriate measures like ice and other, you know, rehab things that we do. When it's beyond that, so there's no specific time frame, but when it's the response is amplified and it's not getting any better, then you're thinking, this isn't resolving at all. And then if you haven't done diagnostic imaging, like x-rays and MRIs, then you would definitely get those first. Your physician should, you know, order them right away if it's outside of the normal time that things should heal, like 2 to 4 weeks, 4 to 6 weeks. If it's a more severe strain, 6 to 8 weeks, depending on those, you know, time frames that we all know of. But when the response when the pain response hasn't changed at all, or it's getting worse, or it's changing. So oftentimes my patients will come in and they'll say, you know, my wrist was the initial spot where I had AMPS, but now it's my jaw, my back, my foot, my hip. Then obviously that's a red flag and you're thinking that's not typical of an orthopedic injury. So it's not so much the time frame, it's more the symptoms associated that the patient's telling you. So if it's amplified in nature, like they're unable to walk on a mild sprain after 6 weeks, you're thinking something was missed. And it's not, far from it, it's not always AMPS, but oftentimes if all those other things are ruled out, they've had blood work, they've had MRI, they've had x-rays, they've had kind of the first base of tests. If none of those come up negative, then you're starting to think, could it be this neuropathic pain disorder? But there's still other tests that need to be ruled out, like CT scans, probably higher level blood work. It's definitely multi-level. So it's not like you do 3 basic tests and then you think AMPS. I've had a few patients that it was not AMPS. So 2 patients. So the patients came in and they presented with longer duration symptoms, but it wasn't AMPS. It was a bone abnormality that was just missed. They needed a CT scan.
Yeah. So
that's important too.
all those things that you just spoke about speak to the fact about, you know, working with providers who really are understanding the whole person. And, you know, again, in orthopedics, it's very common for someone to come in and they are seen by a technician or an aide or a therapist who's got people going on, and they'll look at the ankle and say, all right, like do your ankle alphabet, do your exercises if it's that. And they don't even have the time to listen to the child who is saying, well, now my jaw hurts and now my shoulder hurts. And I worked in those situations where, like, when they bring that up to me, I get stressed out because I'm like, oh, there's another condition and I have to kind of, you know, I have to focus on her ankle, but I'm missing the whole picture.
Mm-hmm.
That really the problem is not just the ankle. So anybody that I would, you know, recommend work with somebody who's going to have that time. We allow that, you know, one-on-one situation, and look for that in any clinician that you're working with, even the physicians, that they're not, you know, kind of running you through. So I think that's hugely important. And
Yes.
as a PT, you know, if other PTs are hearing this, you know, 2 weeks I think is a very reasonable time for some orthopedic condition to show some improvement.
Yes.
If you're not
definitely.
showing any improvement in 2 weeks, it's got to be something else.
Yes.
You should look further into this.
Yeah, right. AMPS or exactly something else. And often the way we practice in this clinic, that it's one-on-one for the hour, these patients throughout the hour have a range of emotions that they feel. So if you only have 10 minutes to work with them, it's just simply not enough, because you have to get through the emotional stress of knowing you're going to be pushed through all these exercises, and the pain's likely going to go up, and then it'll probably go up after the session. So you really need to educate them that this is kind of how you're going to feel during the session after, and you need to build a relationship that they need to trust you, and you're making a pact that you're both working hard to achieve more function. But if you're working with an aide or another PT, or you get another PT the next day, it just won't be a good prognosis.
Yeah.
You really have to create a strong relationship.
Yeah. Go ahead.
I just want to know, once a patient is cured or finished their protocol, what is the maintenance protocol post-treatment to prevent it from relapsing, or is there a certain lifestyle that they have to maintain post-treatment?
Yes, so along with the therapist, PT, and medical doctor, it's really more the therapist, the psychologist, and the PT. They work together to grab strategies that work with the person themselves. So everyone has different strategies. So mental imagery works for some people, art therapy, different things that can control their level of stress, and that's more the therapy component. But the physical therapy part, the exercise component, is regular exercise, like basically a regimen of exercises that work for the patient, and then updates on those exercises. So eventually you'll notice through physical therapy that you'll become more fit, and your endurance will improve and your tolerance to exercises. So that also has to be managed by adding new exercises.
But I mean, like, once you're discharged and say, okay, your AMPS is gone, you don't want them to have a drop off in activity and then go become sedentary again.
Correct.
So
yes.
How much activity
is expected?
Yeah,
so when basically return to what their normal activities prior to that. So if they were a swimmer, they should be returning to swimmer. If they played baseball, if they played basketball. So all the activities that they were doing, normal teenage activities, dancing, whatever they were interested before, they should absolutely be returning to those activities, but they should also be completing their daily exercises for several months to years post-diagnosis of AMPS.
Okay.
Yep, and the intensity is different because they're not in the same level of pain. So the cure of AMPS is that they're managing it. So oftentimes in a large majority, 80% of the patients, the pain goes away, but you're working to control that pain. So you're staying on top of it, you're doing the exercises that were prescribed, you're managing the stress component of it, especially right after the diagnosis and completion of a program. It's not that you complete the program on Monday and then Tuesday you sleep for 12 hours. You have to really be diligent with maintenance of that program. And that's specific to the patient.
And that goes back to what you were saying about function. The whole program is based on return to function. And you're basically bringing that person back to life. If they were not able to participate in their swim team, baseball, school play, even regular school, once they get that momentum going and they can reintroduce back into those activities, that is almost like resuming their old life or getting that new life back, and that becomes therapeutic on itself. Exactly. And that carries some momentum forward. You're almost becoming the person that you aspire to be, and that's really what part of this path is. It's not just exercise, it's reintroduction to the rest of your life.
Yep.
So that's
and so much of the day is instead of right after completion of a program, you're so focused on 45 minutes of exercise 3 times a day. When you start to assimilate back to the life that was before AMPS diagnosis, now you're just naturally active by hanging with your friends, going for a run, playing a game of pickup basketball. It's kind of replaced with that really regimented exercise, with just naturally being an active teenager or adolescent again. So there is a shift in like your awareness of it too. But if you find that some of the symptoms creep back, then you get back on that strict regimen. It should always be there.
Right. And that's where it comes to working with someone that you have a good relationship with, because they get to know you and they get to understand what you really want to do. It's not just about prescribing this exercise, that exercise, that exercise. Because if it was that easy, then this seminar would be, okay, here's 25 exercises. 10 for the first week, 10 for the next week. Like it's not like that. It's specific, it's individualized, and it's that relationship building that goes along the whole way.
Absolutely.
We can continue to take questions, but I want to make sure that we talk about this before it gets too late. So Catherine, who's been working very hard and really had a tough journey, but overcoming, she's taking a negative and turning it into a positive, and we're very proud of her for that. Catherine, you want to talk about your project?
Yeah, I made t-shirts that I'm wearing one right now, AMPS awareness.
Yes, love it.
And then on the back it says, do you want to show it?
Sure.
Let's see the back.
Here. Hurting for a cure.
There you go. I love the image there. That's awesome.
Yeah.
Proud of you.
And then all the money, so far I've raised $302, which is amazing. And so all the money is going to go to, what is it called?
I think it's Dr.
Dr. Sherry's
his
foundation.
Yeah, Stop Childhood Pain. So that it's that function. There.
And all the money's going to go to like educate physicians and families about AMPS and help further research for AMPS, which is cool.
Fantastic.
So cool.
How do we order some t-shirts and
I sent the link, so you should be able to click on it and order.
Okay, so we'll if everybody sees the chat, they should copy that link right now, and if we'll send this out to the rest of our group too. So we'll hopefully get some more awareness out there and people wearing purple t-shirts for hurting. What is it? Hurting for a cure.
Yeah.
Did you come up with that?
Yeah.
So good.
Yeah. Turning a negative into a positive. We love it.
She posted it in the AMPS Facebook group. So if any of you guys aren't on that yet, it's wonderful. Just in overnight, she's had so many people her age reach out to her.
I made so many like friends that have AMP, and
What a benefit.
Yeah.
It's been great.
Yeah. Proud of you.
Because the hopelessness is horrible.
Yeah.
That's
Yeah.
one of the reasons we've been doing these calls is that if someone understands that there is some hope at the end, that pain can minimize, 20% almost instantly, realizing that, hey, there is a path, and I just have to, keep working toward it, and that there is hope, there's light at the end of the tunnel. So thank you for being a light and helping other people and connecting other people and helping people on their journey. So thank you.
Matthew, I just had a couple questions to ask the audience. Some of my patients that have had AMPS, do you mind if I just offer that up and then
Sure,
people
yeah.
can unmute themselves when they
Sure.
want to answer?
Absolutely.
Okay, so I was just curious, for my patients that have had AMPS, what activities helped you to manage your pain outside of the exercises that I prescribed to you? What are some of the art therapy, walking? What are some of the things? You can unmute yourselves when you're ready.
Well, I know in CHOP, we definitely had art therapy. So we had art therapy, music therapy where we got to learn an instrument, which was really nice and calming. And then once every week we were able to do like a music meditation in the morning. So we did that for an hour. We also had other things like going to the pool once every week, as well as yoga Mondays and Fridays. So,
Okay, so they had you do lots of different things.
Yeah.
Do you mind talking about your experience more at CHOP, like how long they had you exercise, what their daily schedule was like? I think that might be helpful for some of the people listening.
So our day started we had to be there at like 8 o'clock in the morning. As soon as we started the day, we were to come in, we would just get our vitals checked like 3 times a week about. And Dr. Sherry would actually come in and he would give us each a checkup in the morning, and he would dance with us every single day, which is really sweet with him. And after that, we went to our first activity. So that's where we do the pool therapy or the other things. We did that for an hour. And then people's schedule like varied, but for me, right after that, I had 1 hour of OT, and during that, I just did my desensitization throughout the most part. Oh, my mom just brought me my schedule on the phone. So I had OT for from 9 to 10:30, basically, 9 to 11. And then after that, I had 1 session of PT. So I had 3 sessions of PT during the day and 3 sessions of OT and 2 sessions of PT. So after the 2 sessions, I had 1 session of PT, and then we normally had lunch for an hour.
A full break.
Yeah, a full break. And after that, we have like our individual sessions with everyone. So that's like individual art sessions where we normally like just create pieces, and in the actual like arts therapy group, we make like a wellness book. So I actually still have mine, and I'm working on it like daily. It's really nice. And we also have either we have our psychiatrist sessions 2 times a week, and that was again for an hour. So after I was done with that, I went back to OT 1 more time, and then finished off the day with PT, and then I was done for the day. Our day ends at 4 o'clock. So it was a pretty hectic day, and normally you just go home and you're like really tired after, but they say you have to like go out for a walk after that, and you couldn't like rest till like 8 o'clock at night. So then that was basically like that was
your day.
Yeah, that was my day. And they have really strict rules over there saying that we can't use the elevator. And that was really hard because there was some points where my friends were to have to carry me up the stairs. So we all helped each other out in that manner. And they really are hard over there. My friend, she threw up 10 times one day, and they still pushed her even harder because she threw up 10 times because of the work.
Yeah.
So.
So the response of, thank you, Alina. That was good description of the day and the intensity of it. So I think initially when you hear something like that, you're like, oh my gosh, it sounds almost like on the torture side. But the response of a throwing up or inability to breathe, or that is part of the whole syndrome. So the anxiety component of the syndrome is huge, equally as important as the pain component. And a lot of those symptoms of vomiting or headaches or brain fog are brought on by the anxiety part. So it's usually not something else. It's kind of combined in this whole AMPS monster. So that's why it's so important to really have a strong relationship with your PT, because they're pushing you through some really uncomfortable symptoms like vomiting or feeling like you can't breathe. So you have to make sure that you trust them, you're willing to do the work and really buy into it, because it's tough work. It's not easy, outpatient or inpatient. It's a real commitment to getting your function back.
Miriam, just wanted to let you know, as a parent, they see, I saw that Alina bonded very strongly with the group, and it works well as a group because the groups looks out for each other. And, I would see Alina, cheering up somebody else if that person was not doing it. And, the same happened for Alina. The senior folks who had been there for like a week, they always took care of the ones that came in new. So any parents who are looking for sending their kids to jobs, at least they should not feel that this is too hard. The kids take care of each other, and it's a very, very bonded group.
Yeah.
That, I just wanted to let you know.
Absolutely. Yeah, that's so much of it too, creating that relationship and feeling that. I think you made a good point where maybe when you noticed someone was struggling, you also cheered them on, totally separate from what you were dealing with. That's that's nourishment too.
Yeah, we were all in the same room, like most of the time. And we only had 6 people in the whole program at a time. So, and it was really sad because like everyone left almost every single week.
Yeah.
But it was really nice.
That's a good thing though.
Come in.
Good. Very, very helpful. Any other comments about that? I just have a couple more questions.
Yeah, I do have to get going, but I thank you very much. It's been
thank you.
Very enlightening and encouraging to see that, people have a road to recovery. So thank you.
Thanks for listening in.
Yep. Okay. Bye-bye. Thanks, Matt.
I color in a coloring book. I use the app Calm for meditation, which has very different, I used to not be able to do it. I just didn't believe in it. And then one day I pushed myself and I was like, I need something to calm my anxiety down. And so I used the app, and there's so many different sleep meditation, which everyone with AMPS has sleep problems, and there's sleep stories. So I do that app. I also just play games with my mom. I play Uno, just anything to distract myself.
Yes. Yep. That's a good one too. Kind of in terms of, the current state of everything, there's so much screen time. So kind of putting that down for a little bit and just playing a good old fashioned card game. So that's helpful too. It's also using a different part of your brain. It's focusing on something external. So you have to win the game or do something, there's all these different parts of your brain that you're using, and it's a really nice distraction from what you're feeling inside. So that's a great idea. Justin, what kinds of things do you do?
I don't know. I mean, I like to play Wii Sports. It's because it's kind of, it is almost like activity, because it's
absolutely.
It's motion censored.
Yep.
So I like to do that. And art therapy, I like to draw. I like to make things out of cardboard, stuff like that. Yeah,
the Wii Sports is awesome. And it's great too, because you're competing against yourself from what you did before. There's, the competition is fun. It's very active. Yeah, that's a wonderful substitute on a day that maybe the weather's not cooperative outside, or maybe you just want to do something inside, but it's still very active. Yeah, that's great. And okay, so now my second question is, what strategies did you guys use to stay motivated during some of the PT sessions that we had together and at home? because I know they're not easy. What words would you tell yourself? What kind of dialogue did you have?
So for me personally, the words that I basically said to myself, also you said to me, were that like just push through it, because the sooner you're done with it, the sooner it's over.
The quicker you do it, then you're done.
Yeah. And during CHOP, it was basically the same thing, just because we constantly had to tell ourselves that you're the person who wanted to be here. And you know, my parents told me every single day that, you know, you're the one who chose to come to this program in the long run, and that you like, so it's your choice. And if you do this, you'll get better faster. And that those were the words that really motivated me throughout the whole program, whenever like we wanted to whenever I wanted to give up, which was almost like every single day.
Yeah, it's hard. And you know too that kind of having the knowledge that if you don't push yourself, you know that you'll have to do it again and again and again. So it's like, oh, am I up against doing it 10 times, or can I just really push through this pain right now and then move on to something else? Just knowing that you can put that behind you and then try to do another task. Yeah, it's the mental component of this is extremely challenging. Catherine, what do you tell yourself when I'm forcing you to do burpees repeatedly?
I try to remember that, like, once I'm done with it, I can do something, like I can go
Different.
get food. I can go sit outside. Like I try to just get it done as quickly as I can. That way I can enjoy something that makes me happy.
Yep.
Also, just don't put it off till later, because you cannot do it late at night.
Mm-hmm.
So.
Absolutely. Yeah, everyone learns that lesson where they find that if they're like, you know what, I don't feel up to it now, I'm going to do it 4 hours from now. 4 hours from now, it'll not be any better. It'll likely be worse, because it's 4 more hours of the worry, knowing that you have to do it. It builds. The feeling of it too amplifies, separate from the pain, just knowing that you still have this bout of exercise to do. So I agree, just kind of addressing it, getting it done, and moving on. And then having to do something that's a little bit more enjoyable. That's a really good tactic. Justin, what do you say? What do you tell yourself?
I remind myself that it's for my own good, and even though it hurts, it'll only help me get better.
Mm-hmm. Yep, it's all for you. It's painful, but you got to do it.
But sometimes I lose sight of that, because all I feel is like it's hard and it hurts in the moment, and I lose sight that it's like that's what actually helps me.
Yeah.
So I just remind myself.
Yep. If I try to tell my patients too, so the pain is there. So the pain is this monster that's always right there, kind of waiting to take you down. So you have to focus on function. So the pain will be there. It's unchanging in the beginning. It slowly goes away, and it does go away, but it's much slower to respond than the function. The function you can see an improvement in 40 minutes. So initially the patient will be unable to do something. By the end of the session, they'll be able to do 10 of them. So instead of focusing on the fact that you still have pain during it, but focusing on, wait, I'm able to do that now. So really, really kind of focus on that part and tune into that aspect of it. And then that helps to create more of like a positive mindset and framework for when you do the next session. Because the pain that's kind of a negative road, because that takes a long time to change. The function can change really quickly. And that's really the physical therapy relationship. It's all about getting more motion, being able to do an exercise, being able to run longer or stand longer. It can, depending on whatever your limitation is, that's a function that you focus on. But that's more motivating to think about what you've achieved in that kind of mindset than the pain part, because that takes a lot longer to change. Okay, one last question. Anything else?
Through that, I have to go off the call, but thank you so much for sharing your stories. All three of you are such an inspiration. Anybody who complains that they can't exercise for an hour, I'm going to think of you, because the schedules and the positivity that comes out from your stories is absolutely amazing.
Thanks, Linda.
Thanks,
Linda.
Okay, last question. So I'm a big fan of mental imagery. So a lot of my patients, I describe AMPS as this like monster that's huge, and you have to like shove it in a closet and close the door. or a big wall of pain that you're just trying to chip away at until you see this crack. So what mental imagery pictures do you guys use that might help some of the people listening on the call? Because I think sharing a lot of these experiences is helpful. Whoever wants to talk first, you can.
I use your wall. I like the chipping.
Okay.
And I try to just like remember what I looked like before and like how I could like play volleyball like insane, and now, and then I'm like, I need to get there. Like that's my goal.
Mm-hmm. So you compare, to your function before. Picture a game, or you scoring this really significant point, or everyone cheering, or you cheering for someone else. The mental imagery component is huge. Often I instruct patients even before a session to take a few minutes and sit quietly. It's a meditation practice and really try to picture themselves achieving a goal. It doesn't have to be volleyball. It could be, running really fast. It could be jumping really high. It could be swimming. It could be anything where they're moving their body in a way that's a little bit of a challenge for them at this time of their treatment, but getting in that mind frame of achieving it and then going after their treatment session. Sport athletes do stuff like this all the time, for a long time they do this, and kind of build that resilience to thinking of those things, because it's easy to kind of fall back into the negative mindset, but then that kind of bleeds into the treatment session, and you want a positive treatment session. So thinking about all those things can be really helpful. Justin, what do you think about? What kind of mental images do you picture?
I haven't really thought of one, but the physical therapist that I go to, he had a really good analogy. He thought of it as like a bucket full of pebbles and then another bucket that's empty, and the more clean and pristine the bucket is, like the more I feel the pain. And what we have to do is we have to keep pouring pebbles into the bucket when I exercise, just to warrant, like, make the bucket more warm, so I can get desensitized.
So you got to like muddy it up.
Right, exactly.
Yeah. Good. Anything that you picture. Yeah, that's a perfect analogy if that works for you. Like you have to kind of get it dirty and kind of get sweaty and push through it. Yeah, that's great. Anything that you can think of that resonates with you and motivates you to push hard so that you can get that function back is perfect. It can be different for everybody. It can make no sense to someone when you explain it to them. It can make perfect sense to them. It's whatever works for you. So that's perfect. Alina, what did you used to tell yourself?
So normally I just say it's like a monster that's having to be fought out. So sometimes like I just like to imagine just, someone just coming and trying to fight off like a big monster, and how it's hard, how they may like die sometimes, and then a new person comes in to try to.
Like when you used to throw the ball at me in the gym?
Yeah.
I remember, yep. You were kind of monster-like then. Good, very good. Yeah, so these questions are also helpful to ask yourself too as you're pushing through exercises. Like, what could I picture right now that'll motivate me to get through this next bout of exercise? What activity after this bout of exercise could I do to kind of calm me down so I can enjoy the next thing that I can do? So all these questions are really important to keep in mind during the session, after the session, at night sometimes when the pain might peak a little bit. So really important to keep this stuff top of mind, and most important is to stay active. So I think, Alina, you nailed it when you said that you weren't really allowed to stop moving until like 8 o'clock at night. So you had a full day of exercise and activity, yet even when you were done, it wasn't like you could go home and sit and stare at the TV for 4 hours. They wanted you to remain active until bedtime.
Yeah, they also, even like going to chop in the morning, sometimes like we did this a few times. My other friends who were also staying at the place that we were staying, they went a little more often, but we had a walk to a lot of people walk to chop in the morning as well. So we like had to start off, and in like the am swing itself and chop is like kind of hidden away. So like
you had to walk to it.
Start from there, you had to go up. Yeah, it was like a 1 mile walk every single morning. Front
Good.
and back.
Yeah, so that was the start and the end of your day.
Yeah, and then at the end of the day, so I was staying at the Ronald McDonald House, and at the end of the day, like we just helped out, and normally like I helped clean tables or something at the end of the day. So it was constantly like 9 o'clock at night. I was done, and then I could finally go to my room and just relax.
Right.
So besides that, it was like continuous, and they would actually like they would make us tell about our day, and they would honestly, like, they punished me if I didn't do enough.
Yeah, there's a lot of accountability. Absolutely.
Mhm.
Yeah. Good. Very, very good. Great insight and information for everybody.
So Miriam, I have a question for you. I guess there's a little bit of concern hearing about the pushing and intensity of exercises and things. And I guess some of this might come off as sort of cavalier, like, oh, just kind of push through it and no pain, no gain. And there's maybe just an assumption that, okay, like if I just have somebody push me, then I can conquer this. And I don't want to sort of take down the mood and sort of take away from what people have accomplished. But at the same time, you know, you're a specialist in this, and tell us a little bit about like all the sort of education that goes behind it, because I wouldn't want somebody to, I guess, start on a path that they're thinking, okay, I'm just going to push myself through this and then end up in a worse place.
Yeah. Okay. So when a patient comes in with an AMPS diagnosis, there's a lot of things you need to kind of uncover about that patient specifically. So the relationship that the patient and the PT builds is really important, because you have to find out how to motivate them to the best of their ability. So if you're pushing them and they're saying, this hurts 10 out of 10, you need to make sure that that's AMPS pain, or is there something else that's flaring up? So in my patient,
because you could actually create an injury.
Yes.
With this, and that's I think why it's important for, you know, a physical therapist to do this, because they can decipher what would be the AMPS pain and what
Correct.
Would be, because as you're having somebody do burpees, you could be creating a knee tendonitis, which is like another problem, which could sort of spiral out of control and then actually stop them from recovering from AMPS.
Correct.
So it's not as easy as just saying, okay, like no pain, no gain, let's go. Like you need to really be, you know, educated and
so it's exactly
the whole system.
Yes. Yep. So that's why it's so important to go to a physical therapist that's had several years of experience with AMPS, because there's a cadence to a AMPS patient that presents. So you're more comfortable with the presentation, you're more aware of what's AMPS pain or orthopedic pain. But if you don't have that much experience, you could be ignoring an orthopedic issue and thinking that it's, oh, that's just AMPS, when it's something else. And that has happened in treatment, where there could be a orthopedic injury that someone's had before and it's flaring up. So you need to treat that condition orthopedically, yet still manage the AMPS symptoms, because that AMPS syndrome wants to take over everything. It'll scoop that orthopedic injury right up and then bring it into the amplified pain life. So it's very important to be aware. And as a PT, they need the education and the background in treating it, but you also need to build that honest relationship with the patient. I always ask my patients, if say they're coming in and they're like, oh, this hurts me today, we have to have a real honest and thorough conversation. Do you think that's AMPS pain? How did it start? How long did it last? When do you think it began? Were you stressed at the moment? Was there something that happened during the day at school or at home or in a sport? So all those things kind of give you a bigger picture of, is it AMPS or is it something else that needs to be referred out or needs to be looked at under a different light, not the, you know, silo of AMPS, because that's really, really specific, and the treatment is then very specific because of that syndrome.
Right. You're not just giving, you know, a whole litany of exercises.
No, it's very, very thought out.
So much more than that.
Yeah. And it's also built up over several weeks. So in the beginning, you're doing a set group of exercises, and then we see if you've mastered that. Then we go on to a different focus, cardiovascular, maybe weight bearing. Yeah, it's not just giving you 35 exercises and then you come back and you tell me how they are. They're very, very thought out and specific to the patient and what their limitations are.
Right. And the other thing is, you mentioned there's people who are maybe diagnosed or think that they have AMPS, and it's actually, in your case, a couple times it's turned out to be something else.
Correct.
Which we want to get those people to the right specialist right away. You said it was a bone condition in one that certainly could have gone, you know, very, very bad for somebody.
Yeah, and you need to have the knowledge of know how to differentiate it, because AMPS, once you get the diagnosis and you're pretty certain that that's what it is, you're pushing them really hard, and you're not ignoring, but you're putting other symptoms behind it. And if that's how you treat, then it could be a little bit dangerous because you're not aware of other things that could be contributing to the pain, but aren't causative of, they're not AMPS, it's something else. So you do need to have a really, really strong education and history of treating these patients, because with each patient you become more informed of the presentation. And I've seen that in other patients. That's very typical of this presentation. CHOP does a really good job of educating you and seeing how they run through their program, but having the history and really, the experience treating them is invaluable. It's really important for these patients.
So for your training, you went to CHOP?
Yes, I went to CHOP and Children's Specialized.
Yeah, and it's
Yep.
Extensive program.
Yeah, CHOP. So basically all the programs that I've been aware of are based from CHOP. So Dr. Sherry is the leading researcher. He's coined the term AMPS. He really does all the research for it. And then from that, other research programs have STEM, but he's the one that established the program, the first inpatient program. So when I went there, Children's Specialized hadn't even opened up yet. I had gone there after, and they based their program after CHOP. They're very similar. I think Boston's might be similar to Children's Specialized, but basically all the programs are based off of that level of intensity. And the ones that, I've had a patient that went to one that wasn't as intense, and it really wasn't as positive of an outcome.
Mm.
So the intensity is a key component in a better prognosis.
Gotcha.
Yeah,
And
that's really important.
You learned all that from
CHOP.
When you went through their training program.
Yep. I observed. I spoke with physical therapists. I spoke with the psychological support. Also, the tutoring, the academic part is very important if it's school-based hours, because it's important to kind of return to the normal routine. Even if you're not in school, it's important to have some time that's carved out to do schoolwork, because then you get used to kind of managing your day, because oftentimes AMPS takes kids out of school and they're not doing schoolwork for months. So reacclimating to kind of time management is also a big part of managing AMPS too.
And it could be another big stressor if they're,
yes. Yep. So yeah, CHOP was a wonderful place to learn. Dr. Sherry was a great physician to learn from. The PTs there are tough, but really, really knowledgeable. Children's Specialized is similar too. Yeah.
Right.
Any other questions?
Miriam, that was awesome. That was awesome. I'm just so enthusiastic about the kids that have come on today and everybody that you've helped. And I love seeing them in the office, and they do really turn into fine young people. And you can see that they're just so much more lighthearted and happy after they've been going for a couple weeks and getting rid of that monster or breaking through that wall. It's just they're becoming the person that we know is inside, but now we're able to see them outwardly. So thank you for providing that to those people.
Of course. Sorry, I couldn't get the link to work. You can see I'm a better PT than IT person. I'll work on it, I promise. I'll send it out though.
Thank you everybody for coming on today. Justin, Catherine, Alina, great to see you all. And we'll be able to reach out to Dr. Miriam. We'll provide her email, and email we'll send out to you guys if you have any further questions. So thanks everybody. Really
Thanks so
appreciate
much. Enjoy your day.
Bye-bye.
Bye everyone.